Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces. Perfect for your commute, coffee break, or whenever curiosity calls. I'm Ghedaa, your host for today's episode, and joining me is Shahd Al Hijani. Yay! To help us tackle a very important topic bone and soft tissue tumors. Shahd, the stage is yours.
Hey everyone! Today we're diving into a topic that looks terrifying on slides, but is actually super pattern based once you see the logic behind it. We'll talk about how to think through bone lesions using age, location, and x ray patterns, and walk through the big name tumors like osteosarcoma, osteochondroma, and the whole gang.
So, if you've ever stared at an x ray with a weird lesion and thought, this could be anything and I will fail this exam, this episode is for you. Before we jump into cases, let's set the scene. When we say bone tumors, we can be talking about benign, malignant, primary, secondary, right?
Exactly. Think of it like a sorting hat for bone tumors. First question, is it benign or malignant? Second question, if it's malignant, is it primary, starting in the bone, or secondary, metastasis from another organ?
And here's our first big high yield point right out of the gate.
Yes, please tattoo this into your hippocampus. The most common malignancy in bone is not osteosarcoma, it's metastasis. So secondary tumors are way more common than primary bone cancers.
But where do these metastases usually come from?
Our top culprit is breast cancer, then others like prostate, lung, kidney, and thyroid. Breast and prostate are the classic ones you must remember.
Okay, great. And now, in order for this information to settle well into our mind, let's drop into a case. Meet Omar, a 16-year-old boy who comes in with gradually worsening left knee pain. He says it's been going on for a few months, gets worse at night, and sometimes wakes him up. His mom thought it might be a sports injury, but now they notice some swelling above the knee. X-ray shows a destructive lesion in the metaphysis of the distal femur with a bit of a sunburst pattern and elevation of the periosteum.
This is the classic exam stem for osteosarcoma. It checks all the boxes. The age fits, he's a teenager. The location fits, it's in the metaphysis of distal femur, and the radiology buzzwords are screaming at you. Sunburst appearance and Codman triangle from periosteal elevation.
Okay, hold up, Shahid. Before we go into osteosarcoma fully, can we take a step back and talk about how we systematically approach any bone tumor question?
Oh yeah, thank you for the reminder. To start off, think of it as a three-step filter. 1. The age of the patient. 2. Where in the bone is the lesion? Is it in the epiphysis, metaphysis, or the diaphysis? And 3. What the X-ray looks like. Is it lytic, blastic, onion skin, sunburst, soap bubble, etc.
So we will kind of build a mental cheat sheet as we go. All right, let's start with metastasis, then primary tumors, and then we will circle back to Omar and his osteosarcoma. Let's say instead of Omar, you have a 65-year-old woman with known breast cancer. She presents with bone pain, and imaging was done. X-ray showed multiple lesions in the spine and the pelvis. What are your thoughts on a case like this?
We're thinking of metastases. Remember, in middle-aged and older adults, especially with a known primary, bone pain is metastasis until proven otherwise.
And from what I remember, metastases can be osteolytic or osteoblastic, right? What was the difference again?
Exactly. If a lesion is osteolytic, it's basically destructive. The tumor is chewing up bone, so you get radiolucent holes. Classic with metastases from breast, lung, kidney, and thyroid. If it's osteoblastic, there's reactive new bone formation. The bones look denser or sclerotic, and that's classic with prostate carcinoma and sometimes breast.
Nice. So keep in mind, on an exam, if it's an old person with multiple bone lesions and a history of solid organ cancer, think metastases. Save osteosarcoma and gang for younger patients.
Exactly. Now let's go back to Omar and really unpack osteosarcoma.
So, what exactly is osteosarcoma?
Osteosarcoma, also called osteogenic sarcoma, is a malignant tumor of osteoblasts, and the key diagnostic feature is that the malignant cells are producing osteoid, which is an unmineralized bone matrix. If the pathologist does not see tumor cells laying around osteoid, they won't call it osteosarcoma.
And on the bone cancer leaderboard, it's the second most common primary malignant tumor, right after multiple myeloma, right?
Precisely. Multiple myeloma is number 1, osteosarcoma is number 2.
You previously mentioned how osteosarcoma is common in teenagers. That reminded me of how confusing they were when we took them. Can you give us a quick overview of the age ranges for the main bone tumors?
Definitely. Ewing sarcoma is most common in ages 5 to 20. Osteosarcoma is most common in ages 10 to 20 years, and again after 40 years in secondary cases, which we'll get into in a bit. Giant cell tumors are most common in ages 20 to 40, chondrosarcoma in ages 40 to 60, and multiple myeloma and metastases in ages above 40 years.
So, if your patient is a 16-year-old with a metaphyseal lesion, osteosarcoma climbs up to the top of the list of your differential. On the other hand, if it's a 55-year-old with cartilage tumor in the pelvis, you start thinking about chondrosarcoma. Age really helps narrow down things.
Yes, for osteosarcoma specifically, there are two main groups. Primary osteosarcoma, which arises de novo in patients below 20 years, usually in the metadiaphyseal region of long bones, and secondary osteosarcoma, which is more common in older adults with pre-existing bone diseases like Paget's disease, prior irradiation, or bone infarcts. These can appear in both flat and long bones.
All right, everyone, grab your goggles. It's location time. Shahd, you got any idea where osteosarcoma likes to live?
Classically, in the metaphysis of long bones, especially around the knee. So think lower end of the femur, which is the most common, upper end of the tibia, and upper end of the humerus. It can also occur in flat bones like the jaw, but the knee region is the exam favorite.
And what are the X-ray buzzwords again?
You've got two big ones. The Codman triangle, which is where the tumor lifts the periosteum off the bone, creating a triangular shadow, and sunburst appearance, which is radiating spicules of calcified osteoid extending into the soft tissue like rays of the sun.
Nice. So if you see teenager, painful swollen knee, metaphyseal lesion with sunburst pattern and Codman triangle, just write osteosarcoma and move on. Now that young adults are out of the way, let's discuss the risk factors for osteosarcoma in older adults.
They love asking that. The big secondary causes are Paget disease of bone, radiation exposure like radium watch dial workers in old stories, and bone infarcts.
And what about the genetics?
About 2/3 have inactivation of the retinoblastoma gene, and it's also associated with Li-Fraumeni syndrome, where you have p53 gene inactivation. So if you link defective tumor suppressor gene to high risk of sarcomas, you're on the right track.
And now, moving on to everyone's favorite part of any disease, the pathology. What does osteosarcoma look like grossly and microscopically?
Grossly, it's a gray-white mass with areas of hemorrhage and necrosis. It destroys the cortex and invades adjacent soft tissue, which correlates with those scary X-ray findings. Microscopically, you'll see pleomorphic malignant cells, spindle, oval, or round, actively producing osteoid.
And where does it metastasize?
Via the bloodstream, and the lungs are the most common site of metastasis.
Okay, then what about the treatment?
Combination of limb-sparing surgery plus chemotherapy, both pre-operative and post-operative. With modern multimodal therapy, 5-year survival is about 50 to 60%, but around 35 to 40% of patients still die due to refractory or recurrent disease.
Here is a mini checkpoint for our listeners. You have a 65-year-old man with prostate cancer suddenly developing back pain. His spine X-ray looks dense and sclerotic. What do you think is happening here? A. Osteosarcoma. B. Osteolytic metastases. C. Osteoblastic metastases. Or D. Multiple myeloma.
And the answer is C. Osteoblastic metastases, because prostate cancer loves building bones.
Great. Now let's step away from the scary malignant stuff and talk about something more chill. Osteoma.
Osteoma is a benign bone-forming tumor. It usually occurs in middle-aged adults around 40 to 50 years and often arises in the skull, paranasal sinuses, facial bones, and the jaw.
And how does it manifest clinically?
Most of the time, it's harmless. It can cause problems if it impinges on the brain, obstructs sinus drainage, or just looks cosmetically unpleasant. Histologically, it resembles normal bone. But here's a high yield pearl. Multiple osteomas should make you suspect Gardner syndrome, a variant of familial adenomatous polyposis or FAP.
Got it! Now moving into cartilage territory. Can you introduce us to osteochondroma?
Of course, osteochondroma, also called exostosis, is the most common benign bone tumor, actually, the most common bone tumor overall. It's a hamartomatous proliferation of bone with a cartilaginous cap, arising from the cortex and projecting outward into soft tissue. Imagine a bony mushroom growing off the side of the metaphysis.
But, who gets it and where is it usually found?
It tends to present in younger individuals, often before age 30, as a firm, sometimes painful subcutaneous mass. Favorite sites include the distal femur, proximal tibia, and the pelvis.
Clinically, why does it matter?
Symptoms can arise from fracture, nerve impingement, or overlying bursitis. There is also a risk, especially in multiple hereditary osteochondromatosis, of progression to chondrosarcoma, although that's not super common.
Wow, this is a lot. I'm kind of zoning out right now. Where were we again?
I really do not blame you at all. But good news, we're halfway through already. So, we started by discussing malignant bone tumors like metastases and osteosarcoma, and then started with the benign ones like osteochondromas and osteomas, but we still have a couple more to cover.
Oh, yeah. Thank you, Spleen, for getting us back on track. Now, let's talk about chondromas and enchondromas.
Chondromas are benign cartilage tumors that arise in the metadiaphysis. When they are located within the shaft of the bone, they're called enchondromas. Favorite sites include small bones of the hands and feet, especially proximal phalanges. They can also appear in the tibia, femur, and proximal humerus, but they're never seen in the skull bones or the vertebrae.
And there are some syndromes with multiple lesions, right?
Exactly. We have Ollier disease with multiple enchondromas and Maffucci syndrome with multiple enchondromas plus soft tissue hemangiomas. Both carry an increased risk of transformation to chondrosarcoma.
Phew, we got to another mini checkpoint. Remind me again, multiple enchondromas with soft tissue hemangiomas are called?
That's Maffucci syndrome.
Fire! Okay, it feels like it's time to level up from benign cartilage tumors to the malignant one. Our contestant for this round is chondrosarcoma.
Chondrosarcoma is a malignant tumor of cartilage-producing cells, chondroblasts. It's the most common primary malignant cartilaginous tumor. Age group is 40 to 60 years, so middle-aged to older adults.
And where does it usually arise?
It tends to occur in the central skeleton, like the pelvis, ribs, shoulder girdle, and also in the proximal femur and humerus.
Does it always come out of nowhere? Or can it arise from pre-existing benign lesions?
Both. It can arise de novo, or secondarily from conditions like osteochondromatosis or enchondromatosis. So if a patient with multiple osteochondromas suddenly has a growing painful mass in the pelvis, your alarm bells for chondrosarcoma should start ringing.
How aggressive is chondrosarcoma?
It has variable clinical behavior. Around 75% are locally aggressive with relatively low metastatic potential, but some are high-grade, very destructive, and metastasize early. The prognosis depends heavily on the grade.
And what about its appearance under the microscope?
Grossly, the tumor is gray-blue, glistening, and semi-translucent, very cartilage-like. Microscopically, it's composed of atypical chondrocytes and chondroblasts, often with multiple nuclei in a single lacuna. There are several histologic subtypes like clear cell, mesenchymal, and dedifferentiated chondrosarcoma.
But where does it go when it metastasizes?
Like many sarcomas, it spreads hematogenously to the lungs.
Time for a quick game. Let us put our thinking caps on to match the tumor to the typical age. I'm going to give you a list of tumors and I want you to match it with their respective age groups. The tumor team is Ewing sarcoma, chondrosarcoma, and giant cell tumor. The age team is from 5 to 20 years, 20 to 40 years, and 40 to 60 years. Okay, Shahd. Let's reveal the answers, please.
Ewing sarcoma, ages 5 to 20, chondrosarcoma, ages 40 to 60, and giant cell tumor, ages 20 to 40.
يجي منك. Now, let's talk about one of my personal favorite exam questions. Ewing sarcoma.
Ewing sarcoma is a highly malignant tumor composed of small round blue cells. It arises in the medullary cavity of bones and is thought to be of neuroectodermal origin. There is a characteristic translocation between chromosomes 11 and 22 that produces the EWS-FLI1 fusion gene. They absolutely love to test that.
Can you remind us? Who usually gets Ewing sarcoma and where does it arise?
As we said, the age group is mainly children and adolescents between 5 and 20 years. It tends to arise in the diaphysis of long bones, especially the femur, and also the pelvis and the tibia.
And what about its typical X-ray appearance?
You'll often see an onion skin periosteal reaction, which is concentric layers of new bones around the shaft, like rings of an onion. That's a classic phrase to associate with Ewing sarcoma.
But spleen, how do these patients present clinically?
They often present with a painful, enlarging mass, sometimes warm and tender, with fever. Because of that, it can mimic osteomyelitis, so you have to keep Ewing sarcoma in your differential when a child has bone infection that doesn't quite fit.
And what about its microscopic appearance?
Microscopically, it's made of sheets of small round blue cells with scant cytoplasm. These cells are packed with glycogen, which you can see with the PAS stain. It's one of the classic small round blue cell tumors of childhood.
How is it treated though? And what's the prognosis?
With chemotherapy, radiation, and surgery, Ewing sarcoma can actually have a pretty good outlook, about 75% 5-year survival in modern series.
That sounds fairly reassuring if you ask me. Coming up next is giant cell tumor, also called osteoclastoma.
Giant cell tumor is a locally aggressive, potentially malignant tumor composed of multinucleated giant cells, which are osteoclast-like, mixed with mononuclear stromal cells, and the stromal cells are actually the neoplastic ones.
Interesting, but who gets it and where does it arise?
It's more common in females, usually between 20 to 40 years. It arises in the epiphysis and extends into the metaphysis. That's super high yield. And the classic sites are the distal femur, proximal tibia, and the distal radius.
Got it. So females between 20 and 40 years and in the epiphysis. What does it look like grossly and on X-ray?
Grossly, it's a solid red-brown mass with hemorrhage and cystic degeneration. On X-ray, it appears as a lytic expansile lesion in the epiphysis, with a characteristic soap bubble appearance, like multiple small radiolucent areas within the lesion.
And under the microscope?
You'll see large multinucleated giant cells with 20 to 30 nuclei and mononuclear stromal cells in the background. The behavior is unpredictable. It can recur locally and rarely metastasizes to the lungs despite being histologically benign.
That was a journey. Spleen, before we wrap, can we quickly classify the tumors into big groups so we keep our thoughts organized?
Of course, the full classification includes osteogenic tumors, including osteoma, osteoid osteoma, osteoblastoma, and osteosarcoma. Chondrogenic tumors include osteochondroma, chondromas and enchondromas, chondroblastoma, and chondrosarcoma. Now, tumors of unknown origin include giant cell tumors and Ewing sarcoma, hematopoietic tumors including multiple myeloma, fibrogenic tumors including fibrous cortical defect, non-ossifying fibroma, fibrous dysplasia, and fibrosarcomas, plus a few more like histiocytic, notochordal, vascular, lipogenic, and neurogenic tumors.
But fret not, these tumors aren't really high yield in exams. Remember, for exams, the big names you must really master are metastases, osteosarcoma, osteochondroma, enchondroma, chondrosarcoma, Ewing sarcoma, and giant cell tumor. The others are still important, but these are the usual suspects in MCQs.
Exactly. And always remember, age, location in bone, and radiographic pattern. Those three together usually point you to the diagnosis.
Alright, Shahd, let's do a quick recap of everything we covered today.
First, we said that metastatic tumors are actually the most common malignancies in bone, with breast and prostate being classic primaries. Metastases can be osteolytic or osteoblastic, and they're especially common in older adults.
Then we moved to osteosarcoma, a malignant osteoid-producing tumor that affects mainly adolescents in the metaphysis of long bones around the knee. We talked about sunburst appearance, Codmine triangle, association with Paget's disease, radiation, retinoblastoma, and p53 genes, and how it spreads hematogenously to the lungs.
After that, we covered benign and malignant cartilage tumors. We discussed osteochondroma, the most common benign bone tumor with a bony outgrowth capped by cartilage, and chondromas in small bones of the hands and feet, and the syndromes O'Leary disease and Maffucci syndrome. Then we move to chondrosarcoma, a malignant cartilage tumor of middle-aged adults, usually in the pelvis, ribs, and proximal long bones, with behavior that depends on tumor grade. We also talked about tumors of uncertain origin, Ewing sarcoma, a small round blue cell tumor in children and adolescents, usually in the diaphysis, with translocation 11-22 and an onion skin periosteal reaction, often mimicking osteomyelitis. And giant cell tumor, a locally aggressive epiphyseal lesion in young adults, more common in females, showing soap bubble appearance and osteoclast-like giant cells in a stromal background.
And finally, we reminded you of the bigger classification and how age, bone site, and radiology work together like a 3-key code to unlock the diagnosis. Now, before we end today's episode and say goodbye to you all, we have a few questions to see if you guys were actually listening. First up, onion skin periosteal reaction plus fever plus midshaft pain in a 14-year-old. Which translocation is responsible? A. Translocation 9-22, B. Translocation 11-22, C. Translocation 8-14, or D. Translocation 15-17.
That's B, translocation 11-22, which is Ewing sarcoma's signature.
Next up, which tumor is linked to retinoblastoma inactivation and Lee-Fromani syndrome? A. Osteosarcoma, B. Ewing sarcoma, C. Chondrosarcoma, or D. Enchondroma.
And that's A, osteosarcoma.
And finally, our last question for today. Patient with multiple osteochondromas develops a growing pelvic mass. What are we worried about? A. Osteoid-osteoma, B. Chondrosarcoma, C. Ewing sarcoma, or D. Bone cyst.
And the answer is B, chondrosarcoma.
And that, unfortunately, brings us to the end of today's episode of PodBites. Hopefully now, when you see a bone tumor question, instead of panicking, you'll calmly ask yourself, what's the age? Where in the bone is it? And what does the x-ray look like? And once you answer those 3 questions, the tumor usually reveals itself.
Thank you so much for listening. If this episode helped make bone tumors a little less scary, share it with a friend who's also suffering through pathology, and feel free to replay the question segments as a mini revision before exams.
Don't forget to follow PodBites, leave us a review, and let us know which topic you want us to break down next.
Until next time, stay curious, stay consistent, and good luck with your studying. This is classic STEM for osteosarcoma. حسيت في شيء غلط بالجملة هلا استوعبت. اوكي. يا اخي والله المايك حيجلطني.
And what about the treatment?
ليش قلبتي إيطاليا فجأة؟
I don't know. Here is a mini checkpoint for our listeners. You have Okay. Here is a mini checkpoint for our listeners. You have a 4... Why do I keep saying
ليش بتغيري الرقم؟
It's 65.
C. Osteoblastic metastases. Because طيب okay.
Yeah, صراحة it was very underwhelming. The
My
answer is
bad.
C.
My
C.
خلص. I'm sorry.
Can you introduce... Kill yourself. Okay. Wow. What? Okay.
أنت عن جد يزون دافت.
For real. Wow, this is a lot. I'm kind of zoning out.
Sonic.
Zoning. Okay, again. Wow, this is a lot. I'm kind of zoning out right now. Where were we? Where were we again?
غيداء بالله نخلص.
No, I need to do it in one breath. I can't. ثواني.
مالك؟ شاهد ما أخذتنا محتوى بس. يلا. All year صح؟
Yes.
هدول دورنا عليهم.
هذا مفوت شي.
مفوت شي.
تك تك تك.
لا. Fire.
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 Damn.
غدا انت تحكيها كل يوم على فكره يعني ليش علقتي هلا؟ لايكات
فاير. يا اخي ما عم تزبط. طيب بنت يا طيب فاير. اوكي جريت. ما بتزبط اكتر من هيك مع اني انا اللي كتبتها يعني انا اللي suggested.
Like many sarcomas, it spreads hematogeneously. علقت مخي الأو نسيت أنا أحطها. لا إنه كيف عن جد hematogeneous by the blood.
ايوه
كله بسببك يا شهد.
أيوه.
never speak again.
Between 5 and 20 years عدناها مليون مرة by the way.
It's okay عشان يتذكروا.
خلاص يعني it gets to a point.
يتذكروا عشان ما ينسوا. Their attention span is very low. No offense. No offense.
ترى none was taken لحد ما you mentioned.
And that unfortunately brings us to the end of today's
قلت الكذب. Until next time, stay curious, stay consistent, and good luck with your studying.
Woohoo!